Okay, today we have a pretty full agenda. But before I start, let me go ahead and start with the land acknowledgement. So I'm in West Olympia, the traditional lands of the Coast Salish people, including the people we know today as the Nisqually, Squaxin Island, and Confederated Tribes of the Chehalis Reservation. I honor their ancestors and leaders who have been stewards of this land and water since time immemorial. We acknowledge their stewardship, their forced removal, and their continued fight to live on their ancestral lands. Thank you and welcome to our second workshop today. If you don't know me already, my name is Ashley Bell. I am the lead implementation for 5229, which is the Health Equity Bill passed in 2021 legislative session. And I am also the Behavioral Health Program Coordinator. Ross, will you introduce yourself?
Yes, hello, my name is Ross Bellore. I am a policy analyst with the Health Systems Quality Assurance Division, and I'm one of the policy analysts assisting Ashley on implementing 5229, and I use he, him pronouns. Thank you.
Anyway, so. Okay.
Hope, I will have you introduce yourself.
Sure. Hi, my name is Hope Kilborn, she, her pronouns. I am also a policy analyst with Ross from the HSQA division working on this project. It's good to be here.
Then we'll go with Dan.
Hi there, my name is Dan Frank. I'm with the Office of Health Professions, he, him pronouns, and I'm grateful to be here and I help Ashley out with this project. Thank you so much.
Thank you. Is there anyone else from DOH that would like to introduce themselves? Seeing and hearing none, how about other state agencies?
This is Christine Morris. I'm an office chief at DSHS, Aging and Long-Term Support Administration, Home and Community Services. It's a long title. Anyway, I'm in the Training, Communications, and Workforce Development Unit.
Okay. You're hearing no more introductions. For the rest of everyone, if you would introduce yourself in the chat, and we'll go ahead and move on to the next topic. Just a few meeting reminders. Be mindful and respectful to all that attend, and please raise your hand to speak. Staff will call on you to share, and keep your mic muted unless you are sharing. Also, please be aware of the time speaking. If there's a lot of people who have their hand raised, staff may ask you to finish your thoughts. And then please stay on the topic of health equity. Today, we're focusing on draft rules. This bill has passed, and so we're working towards getting a set of rules that we can all benefit from. And so, Dan, I'm going to hand it back to you for some tips and tricks for navigating Zoom.
Perfect. At the bottom of your screen there that you're viewing, what you should see is a picture of a hand where you could raise your hand. If you would like to put a comment in, we're asking that you just raise your hand. We will call on you, and next to that, you will see a unmute button. You'll need to press that unmute button, go ahead and speak. And then when you are done, just remember to mute yourself again. And that's it. Any questions, let me know. Thanks for being here.
Thank you very much. So health equity. So I do this quite often, and today I changed my PowerPoint a little bit. But the Integral Substitute Senate Bill 5229 was passed by the Washington State Legislature in 2021. And a lot of us refer to this bill as the Health Equity Continuing Education Bill. And what this bill does is requires that professionals must take continuing education on health equity every 4 years. And the goal is to help providers think about their own impact on others and change the way we work with others. During our listening session, we heard a lot about the struggle and the experience of individuals who've experienced health inequities. And we can take from what we learned from those listening sessions and really connect it to solutions and what training topics are necessary to help work towards more of an equitable environment. So the model rules, which are also known as minimum standards, must be complete by the beginning of next year. So January 1st, 2023. And then we must identify a free training, July 1st, 2023. And then with this training will meet our minimum standards that we're working on developing today. And then the professions must adopt and begin training January 1st, 2024. Something to really note is that when it comes to the secretary professions, that minimum standard that we set today would apply for those secretary professions. And so those are professions under Title 18 that have a continuing education requirement, and they are designated as secretary professions. And the list is quite long. And so these minimum standards that we develop today will be adopted by these professions unless they choose to open up their roles and add on to the training that we decide today and next week. So Ross, did I miss anything or anything you would like to clarify?
No, that's great, Ashley. Thank you.
So before we get into the rules development, and I'll stop sharing my screen so that we can prepare to have the draft rules, I was asked to do some research. And a lot of that research really went around what type of programs that really point to health equity exist now. And so I was able to do an audit throughout the United States, look at some programs that are here in the US, also in Washington State. I was also able to look at conferences and really find what those themes are. And so that today will guide our conversation. But first, we'll talk about some of the changes we made. And then we're really going to hone in on that training content section. So Ross, I'm not sure if you're ready to share. Perfect. And so what we did was in this first section, the purpose section, we did some cleanup. Last workshop, it was brought up that perhaps maybe we were saying the same thing in multiple spots. And so we were able to take off that last sentence, which was a suggestion, and it is defined and mentioned further on in the rules. Definition section. So it was suggested too that we define what health equity is. And so I went ahead and I pulled from our one pager, which is a reflection of Department of Health's definition of health equity. And I was able to add that in. So you'll see in red with the underline, this is kind of that definition in there, as well as some of our edits to that definition over the last week. Next, we went to healthcare professional, and Ross also looked to see kind of what the language looks like. Hope also did throughout the chapter, and there was no consistency. So we took the language that was from something similar and this is what we got. A healthcare professional means an individual credentialed or holding a retired active credential in one of the health professions listed. And then we put, which was the recommendation, with a continuing education requirement. So this definition is for this brand new rule section that we're working on. All right. Now we did remove structural competency and cultural safety from the definitions as they are already defined in the bill language itself. All right. So then we looked at what is the health equity continuing education program requirements. And so we were able to look at the comments provided and really take them into consideration. So we do have some wild cards in this section. One of the things I will ask though, is that we come back to it after we talk about the training topics, as it might provide some more clarity in this section. So the training content, a lot of what we noticed was throughout the last workshop, we could recognize that this training needs to happen. It's very important. And we could recognize that during our listening sessions, individuals talked about the impacts of health inequities. And although there were some solutions, we never really got to defining what that training is and what those topics are that are required. So what I did was, throughout all my research and all the conferences and all that that stuff, I was able to find some core themes and then link it back to our listening sessions. And these themes might resolve some of the stuff that was brought up at the listening session. Now, this is just the stab at the dark. And what I really would like to work on today is really defining what these topics are. And so we need to think about, what problem are we solving? And how does this topic solve that problem? All right. So to begin with, I did put reducing barriers to accessing care for patients from diverse cultures, groups, and communities. A lot of my training had a lot of the training I looked at had various topics on different groups of individuals and how barriers to accessing care has caused some difficulties in receiving their highest health potential. And so I was able to make this a little broader. And instead of honing in on different groups of individuals, I was able to say, hey, let's look at barriers that are existing for accessing care. Implicit bias training was mentioned during this last meeting, and it was mentioned a few times during our listening sessions. I also saw that it was a common theme throughout the listening sessions, as well as the conferences and the continuing education that exist. What I did here was I took the definition of implicit bias and put it in there for people who don't maybe know what that is. And I would like to talk about that more and define that. Inclusive healthcare strategies to advance health equity was another common topic. Understanding culture and its role in health equity was also a topic in a lot of the trainings, but we also had a huge push towards culture and language as being one of the barriers for receiving equitable care. Perhaps individuals have forms that are only in languages people can't speak, or there's assumptions that are made due to a name. Also, the influence of race and place on health. We heard a lot about deserts and where there's a lack of care, and the system itself prevents individuals from receiving the care they need. We also heard a lot about racism in the healthcare system. And so I really would like us to kind of define maybe what those topics are. We can remove topics, we can add topics, but I would like to have a healthy discussion about these today. Ross, we can go ahead and go down. All right. And so what you'll see lined up is kind of a little bit of the conversation we had last week and the language from the bill. And the bill talks about how it may include these topics or anything else. And so these are kind of here to jog your memory. And with the delivery, the message, I made sure that we included the bill language in there. All right. And then last but not least, this minimum standards for training quality. And there was a lot of conversation about that last workshop as well. And so we'll take the last about 20 minutes of the workshop and really hone down again. And I'll ask you some questions very specific to this training quality section. But we heard you loud and clear. And we have taken out some of the subsections, A and B, which states what education the individual needs to have and also what type of credential they hold. All right. And I think that's all. We didn't do anything to this last section, and we will not actually address it today. Did I miss anything, Ross?
No, I think you did a good job, Ashley. And if anyone has questions as we start moving through the rule again, please feel free to raise that.
And I do see something in the chat. Oh, well, you know what? We'll go to that section right there. So Ross, can we go back to the training content section and maybe have a discussion around this? And so the first question I have is, must the training include one of these topics or all of these topics? The language seems unclear as to whether this is an and or situation. And so that's kind of the conversation we're going to have today. It's vague because I had just listed some of the topics right here, but I really like to hear from everyone who's present, whether or not. So Jesse, you have the mic.
Thanks. I'm just hearing a logistical issue, and I'm wondering if I'm thinking about this the right way. But y'all are going to have to identify a free training that meets our criteria, but there's no money to develop a training. Is that right?
That is correct.
So we have to make sure that what we imagine can exist too in a free form.
Yes, and so that's why I took a pretty big chunk and really got down and saw what was offered in ways of health equity. Now, the positive is that a lot of those topics listed in the bill are actually topics that are addressed by continuing education and conferences. Now, as a professional, I would attend the one that maybe meets my niche or my area of practice, or I could be very generalist. Gail, your hand's up as well.
Thank you, Ashley, and thanks to everyone for all their hard work on this draft. And Gail McGaffick here representing the podiatry and massage professions. I have a structural question. The training content, the statute pretty much has a fair amount of language there, and it says the course topics may include but not be limited to. So And I understand what you're trying to do here by pick out the core pieces, but you've said it must include the following elements. And I'm not saying these aren't all important, but I'm not able to sync this up to the statute. To me, a suggestion would be you refer back to the statutory language and just simply say that for the training content, you refer to what's in 437613. So again, I think my question is structurally related. How do you take language that says may include but not be limited to and turn it into must?
I'll speak a little bit, and then Ross or Hope, I know that we were discussing this. So we're really trying not to, so all those different topics that were mentioned, or those elements, do actually fit into kind of the broader portion. But that's why we're coming here, is because we want to hear from everyone who's present. Do we need to expand on these topics? Do these topics actually solve the problems and address what was shared during the listening session? And also, by defining what these topics are, we then also have something that is, measurable in terms of, did someone complete this training as necessary? And Ross or Hope, I'll kind of let you speak more to the structure and the use of statutory language or rule language, the use of the language in the bill in our rules.
Thank you, Ashley. I can start. So I think our goal here, going from the first draft to this, was to get away from using the exact statutory language here and trying to edit that and to put in place, like Ashley said, what she'd learned from her past, as well as what we heard in the listening sessions, to make sure that the training content spoke to what we had heard during the listening sessions. But I think your point, I think Gail, is a good one, that we may need to add language that trainings may include, but don't necessarily have to include all of these different topics. I think that point is well taken. And I don't know if Hope or Ashley has anything else to add.
No, it's definitely something good to reflect on, and it's a good comment, Gail, as well.
Thank you.
Billy, your hand is raised.
Hi there, Billy Dickinson with the Washington State Medical Association. I just kind of want to echo what Gail was saying. I think her point is well taken. We understand the department's desire to put some parameters in place here, but we just think it might be tough for all CE courses to meet the requirements listed here. And it might actually eliminate some in-depth courses or courses covering topics not listed, which may be particularly valuable. So just wanted to add that.
Okay. And Ross, I see you're adding those comments in. Autumn.
Hello, good morning. I'm Autumn from the Board of Massage. I had a suggestion for 1.1a, reducing barriers for a content. Perhaps training in just general accessibility training for, ADA and also digital online accessibility might be helpful.
All right, it's 1:33 p.m. So welcome back from your break. There's a lot of good comments in the chat. I do want to say, Patrick, you should hold on to that thought, because after we identify this training standards, we'll go back and circle through and say, okay, is this actually feasible to have these quality standards in place? And there's been some conversation about this exactly what you mentioned from a health equity point of view as well. So definitely not going to forget you. It's just, I want you to hold that thought because I want to come back to it. And then there is a bulleted list of topics under 1A was suggested, which is, we'll take note of that. And let's talk about the goal. What is the ultimate goal of the training? So the bill has language, it's really looking to, I guess, going outside of the bill language. As a professional, it's really so that I can be reflective of my thoughts and my attitudes and my beliefs with the individual I'm working on, so I can maybe change the way that I work with individuals. Maybe I can also reduce some of the structural and health inequity issues. And so it's a little bit more than just walking away with minimal knowledge, but really we're hoping to make a change in the way a professional actually thinks and really give them the knowledge so they can apply these health equity skills into what they do, whether it's running a business, whether it's working directly with individuals in a medical setting, or even a mental health setting. It really doesn't really matter. We just want our professionals really to have a increase in knowledge and practice and command of these health equity topics. And so when we talk about this, we've heard the problem, right? Individuals have shared their experience, going to a provider who assumes that maybe they're overreacting because of the color of their skin, because they're emotional. And how can we really take these topics where a professional, a provider would say, and respond differently in that situation instead of being dismissive? Or perhaps, how do we set up training in a way that maybe if you own a private practice, you can think a little bit outside the box on the services you offer? As one individual shared, I have to take the whole day off of work just to go see the provider, because with the travel time, the distance, the waiting there, everything, I just don't get healthcare because of where I live or where I work. Or maybe I can't afford to take time off of work. And so this health inequity goes very, very far, and we're not going to be able to solve all the problems. But if a healthcare professional is able to conceptualize and apply what they've learned, perhaps the system will be a little bit more equitable. Paula, your hand's up.
Yeah, hi, Ashley. Thank you for all the work that you've done. I'm Paula Houston. I'm the Chief Equity Officer for UW Medicine. And I just thought it would be a good time to jump in. All of the things that you're saying are included in the pretty robust training that we've already started here at UW Medicine. We have put together what we're calling our foundational training that all members of our community, faculty and staff, are required to take even before this came out. And we have 5 key content areas, and one that I see is not mentioned here is, and I'll just run through the 5, but one that isn't here is identity, privilege, and intersectionality is the first one. Then we'd have the history of race, racism in medicine and science, implicit bias and microaggressions, social determinants of health and health disparities, and gender and sexual diversity, which I also don't see here. So those are the 5 key content areas that we are doing 90-minute modules on for all members of our community. And having done a lot of training, and we did listening sessions when I first took on this role a little over 4 years ago, those were kind of the 5 areas that some people were already being trained on. Those were the ones that we found people had the biggest gaps in, and that were really going to allow us to focus on healthcare equity and how to deliver better better health care. And then that was my other thing, is that I see that you're talking about health equity rather than health care equity. Those are slightly different things. And I think it might be beneficial to really define those two so that people can target the training, where we really are talking about healthcare equity. How do we deliver better care and make sure people are having a better experience in our health system? Whereas the health equity, that's more of their health status, that has to do with social determinants of health, while folks are out in the community. So I just wanted to share that.
And thank you so much for sharing that. I really appreciate that. And there's a request, and both in the chat and then from me. Would you please repeat those 5 topics, or add them into the?
I will put them in the chat. My training manager, Lee Davis, is also here, and he can help me if I forget anything. So we'll both, there's Lee. Hi, Lee. Thank you.
You're welcome.
Yes, we'll, if you have any other questions while things are going on, both Lee and I would be happy to answer those for you. But yeah, I'll go ahead and type those in the chat.
Thank you.
Mm-hmm.
I have
Me-
sorry, Ashley, can I ask,
Okay.
I just wanted to ask a quick question of Paula. Just the differences between health equity and healthcare equity. Would you recommend any changes to our current definition of health equity?
Let me move the chat thing. That is a good definition of health equity, and our office is the Office of Healthcare Equity, because we're really talking about the delivery of healthcare to people. Your definition of health equity is fine, and it's talking about their health status and their full health potential, but it doesn't necessarily address, well, how are we as healthcare professionals going to do something that is actually going to affect their health equity? Does that make sense?
Yes,
That
it
does.
Thank you.
You're welcome.
Do we have any other comments or thoughts now that Paula has shared? Jesse.
I think Paula's comments really helped me think more about the question that Christine asked, like what's the ultimate goal? Because it sounds like what Paula and her team have developed is around a level setting training, like everyone's going to come in with this base knowledge. And for me, the question still remains of, is that what we want from these requirements, or do we want a requirement that would allow folks to use trainings that we're pushing them and keeping them at their growing edge as meeting this requirement? I hope that made sense.
And I think ultimately, you know, what are you guys hopefully obtaining? I think the difficulty with this bill, right, is we want providers to acknowledge and to work towards health care equity, but each profession maybe works from a different angle. And so how do we also make these topics where we can also apply them to different healthcare professionals? So, for example, throw veterinarians under the bus here. Most of their time is spent with a patient that is not, you know, a human, but that doesn't mean that they don't interact with people who bring their animals in for care. So how do we tailor maybe a training where we have the expected outcome so it can work for that, And then perhaps it can work in the behavioral health fields where every patient is a vulnerable adult, really. And so maybe that's the discussion we need to have is, what do we want to see change? We have all these problems. We have all these things that lead to, that really highlight the inequities of the world. But what are we hoping maybe to achieve with this training? And Paula, I see your hands up. I'm not sure if it's still up or if you have anything to add, or she's like, nope.
I forgot to take it down.
So do we have any thoughts on that? Go ahead, you have the mic. Manjit? I'm not sure if can you please pronounce your name or say your name too?
Absolutely. Thank you. My name is Manjeet Sekho, and I'm Director, Learning Course Development at SEIU 775 Benefits Group. And I'm so glad someone asked that question about what is the ultimate goal of this training, because I have been looking at it from the lens of what could be the goal of this kind of training for home healthcare aides, which is our primary audience for our training programs. And one of the things that I think might be relevant is, yes, the self-reflection piece is important, because we want our HCAs as they go into their clients' homes to be aware of their own biases and their own attitudes that they might need to really confront through this training. But also, my question was, how do we make this content, which is great, it's very in-depth, how do we make it actionable for a healthcare aide or for home care aide who may actually also fall into the groups that receive unequal healthcare? And so it's one thing to recognize your own biases. It's another to learn how to recognize the inequities that you're subject to as a patient yourself. And then it's another set of skills where you learn to advocate for yourself, and you also learn to advocate for your client. And so what I'm thinking from putting on my hat of an instructional designer and really thinking about, how do I turn all of these things that I see on the screen here into learning objectives? And I'm thinking about, what does the HCA need to know? What should they be able to do with that information? And I'd like some discussion or maybe some guidance around how we can equip them to have some of these conversations on behalf of their clients.
Thank you for sharing. Does anyone have some thoughts on the questions proposed? I know there's some comments in the chat, but how do you make learning more than just I'm taking in information, but actionable? I'm going to take this moment to catch up on chat. There's a lot coming in. So some thoughts reading the chat is someone shared, oh, Christine, your hand's up. Thank you for bailing me out.
Well, if, I go back to the bill itself, what was the original bill? And it's talking about the 5 core competencies for structural competency training. And so going back to what Manjeet was talking about too, when enabling people to be able to recognize the structures that shape the clinical interactions, developing a extra clinical language of structure, rearticulating cultural formulations in structural terms, observing and imagining structural interventions, and developing structural humility and cultural safety training. So when you look at it in terms of that, you kind of have to have a baseline on really how should you be treating the patients that come in light of these 5 core areas. Because I think, when you talk about the different, and this is just me talking out loud, so forgive me because I'm an internal processor and this is off the cuff, but when you look at all the different professions this is going to impact, I think in terms of, if you're going to talk about education and each area being different because of who they serve, whether it's massage therapy or podiatry or, et cetera, you could create the foundational for how are you inclusive with everyone in a healthcare setting when they walk in the door, or even before that on the phone. And then, provide maybe continued ed that's more specific to each profession, if you will, that relates to this. Because a lot of it would have to be, I would imagine, scenario based, right? When you're trying to help people, interact. So that's just my 2 cents.
Thank you.
And I don't know if there's any, I haven't researched the types of courses that are out there, because we at DSHS are looking at this for home care aides, but they don't fall under this ruling. And so we're looking at what we can create towards this end too, to help people be more aware of what their rights are when they do go into a healthcare setting. Do you have the right to have an interpreter and those kinds of things, and to schedule accordingly so that it's not your child, doing the interpretation for you. So this is huge. It's huge. So I applaud you for taking it on. Thank you.
Thank you. And Paula, you have your hand raised.
Yeah, I just wanted to address the issue of having to tailor it so specifically for individual professions. And we have already explored that, and I don't want to send people down that rabbit hole, because we do scenario based, and those 5 key content areas are applicable to, we haven't found anything it's not applicable to, let's put it that way. And we do then have certain areas where we have to use examples that are more relevant to a specific area, but the basic foundational content is applicable to everything that we've come in contact with so far. I mean, the history of race, racism in medicine and science, that's going to cover everything, because we start back with, how was race even created as this social and political construct? And then how was the medical field part of the leadership that perpetuated it with slave medicine? And then what does that mean, and how is that perpetuated? So it really starts with a thread that you can pull through everything. Then when you get to specific examples of microaggressions or implicit bias, then you can say, yes, for a massage therapy setting, this is may be what happened. For a nursing setting, this might be what happened. But don't think you're going to need to create an entirely different training for any kind of a specific area, because I think that's going to be very difficult and send you in a direction that you're just not going to be able to fulfill from our experience.
Thank you for sharing that insight. And then in the chat, it's been moving along. Someone asked, hey, the required suicide training for the health professions has varying requirements for different professions. Could it be tailored in a similar manner? And then there was a link provided of what that looks like. And I know we copied and pasted, for lack of better words, the suicide training from above, which does have a little bit more different requirements, but you're right in that it's similar in that we're creating this minimum standards for rules, and we know that it'll apply to secretary professions unless they were to go above and beyond and make some clarifications and open up their particular profession's rules. But we also know that the boards and commissions, they're paying close attention and their own rulemaking authority. And so it's really important, as said before, to make sure that this training captures all the health professionals, but provides that opportunity for people to specialize in their profession. So, and then some other things I saw, it's someone seconded that and said, I always prefer training that can be tailored to my job role. And let's see, I froze. Okay, I'm unfroze. It might be helpful to include a discussion about racism without racist. And very something to keep in mind. We might want to be careful about starting with the patient who comes in and address who can and does come in. Someone said, perhaps providing training on how to talk about equity with patients and clients. And then someone said, this is a two-sided problem, and this side addresses the problem from the provider side. But how do we inform patients burdened by existing barriers? And so I think all those comments will be logged, Ross. You're already on it. So I would like to ask, do people like UW's healthcare equity training? Is something missing? Christine, your hand's up. Is it still up? Or did you raise your hand again?
Oops. Sorry. I will put it down.
You guys are letting me down.
Sorry.
I thought you were going to talk, Ken.
You're doing great.
So is there anything missing? Does it capture the intent of the bill? Does it create buckets per se for training may include, but is not limited to?
I have a question, Ashley. This is Ross. Thinking back to the language of 5229, and it's encouraging the department to work closely with those with lived experiences of health inequity or inequity and racism. And we've included in 1A through E some examples that we heard in listening sessions, and just trying to take that in with what we've heard today. Are these too specific? Do these need to be put in as part of the 5 topics that UW listed as part of their healthcare equity training, or the 5 core principles that were in 5229? Do we need to take a step back and put these into bigger, principles or groups, or are these enough to stand on their own? Does that make sense?
I think you're asking where do these go? Ross?
Yeah, I guess I'm just hearing the topics that, we're talking about, there's a little bit of a tension between being too specific, whether it be topic wise, mandating too specific of topics, or profession specific, being overly specific about that, and just making sure we have, broad enough groupings that these would fit underneath.
I think that's a good question for everyone. And Christine, your hand is up.
Yeah, I'll lower it right now so I don't forget. Okay. So I think, what Paula was saying around, it sounds to me like what UW is offering as a training is a really good example of exactly what you're supposed to be looking for, right? So when this bill says, you need to find trainings that are relevant to what they're asking of you, this list here that you've got on the screen is, just kind of I would say an outline, and then you could say that, these particular trainings meet these definitions, and you could then subset each section with the types of trainings that you're talking about or that is already available out there. Because, having worked with a lot of different stakeholder groups, everybody's interpretation of a rule is different, and how they choose to read it. So, it's pretty broad to me, in my opinion. If you say reducing barriers, that could be a huge list of things, whether it's a disability, whether they need an interpreter, whether, just any number of things. If it's travel, if it's finances to get to the appointment, it's all of that. How far do they have to go? There's a lot of different areas in terms of barriers. And then bring up, all the other having to do with the cultures and the groups and the different communities and just the way their ways of being, I guess, is a good way to put it. So it's almost as though, you've got a pretty good outline of what it is from the feedback that you've gotten so far. And then if you look at what the trainings that are out there that are in existence already, is there, are enough trainings out there that people could then get what they need in order to do this required training that the bill talks about? And if there isn't, do you need to then, look to have more, I guess, either created or down the road, because you have to, I'm hoping, report out on all of this too. I can't remember, it's too many bills this year, but am I making sense? Because it's almost like working backwards. You look at what's out there, you see whether or not the standards that you think it should apply to, are met by what training is already there. And then you just fine tune as you will and do a final maybe session to see if people are in agreement.
Thank you for that.
Mm-hmm.
I think it was Autumn. Your hand was up. Is it down? Think so. All right. Oh, no, Autumn's hand is up. Go ahead, you have the mic.
Thank you. Sorry. I was just wondering what inclusive healthcare strategies to advance health equity means. Maybe it was discussed in the first workshop and I missed it, but yeah, could someone explain that maybe?
I can. So I saw in multiple trainings, both online and in conferences, they were talking about strategies in terms of different groups of individuals. And so what I did was I just kind of widened it out and then looking for feedback. Is it too vague? Does it actually meet what it needs to be? But those strategies can include maybe not having gender markers on forms, so that, and the list goes on. And Lee, your hand is up, so I'm going to hand over the mic to you.
Thank you, Ashley. So my name is Lee Davis, and I'm a training manager for the Office of Healthcare Equity at the University of Washington. And there was a question earlier about how to disseminate the training. So what we do at the University of Washington School of Medicine is we have solicited cohorts, fall cohorts, spring cohorts, 2 cohorts per year, and they help us disseminate the training that Dr. Paula Houston has mentioned, those 5 key content areas. We train these cohorts in those sections by key content experts. We practice also providing feedback to the cohorts as they train with their own particular groups to see if there's other methods of providing this training to the 28,000 population. So I think that's a great way to help champion this daunting and monumental task of trying to transition to an anti-racist institution, is by collaborating with all people within the community or your department.
Thank you. I really appreciate that. And it seems like you've had quite a bit of questions in the chat. So it seems like the training, so various forms of training over the last 4 years, and then you formalized the 5 key content areas last year. If you don't mind me asking, how did you come up with those 5 key content areas?
Yeah, I'll be happy to answer that. So when I first came to UW-Medicine a little over 4 years ago, our very tiny little team of 2.5 FTEs began going around and really listening to what questions people had, kind of what gaps in people's knowledge. And so we began just formulating, okay, here's what people are asking for. So we started kind of doing some training. We also knew there was training going on in various areas around the system, and kind of gathered that information. Then there was a formal team put together in 2019 when our leadership mandated that all faculty have EDI training. So there was a team of faculty, staff, students, residents, administrators that came together and determined kind of where the gaps were, what were people already asking for, what were people already training on, and that's how we came up with those 5 key content areas.
Thank you. Thank you for answering that.
Sure.
Lori, your hand is raised.
Thank you. And I did just put something in the chat. I apologize that I've not been on previous rulemaking conversations on this subject, but listening today, I am concerned with making sure that whatever's drafted is within the confines of the bill, but also is respectful to small practitioners. So I represent mostly sole proprietors, and sometimes there's 4 or 5 providers in a clinic. And the examples given by the UW are great for the UW and larger facilities and health systems, but they're very unrealistic for my association to put together with our commission to present to our members and their staff and their patients. And I see them as 3 potentially different types of stakeholders with a nuanced change in the training for each of those stakeholder groups, whether they're a patient, a staff member, or a practitioner. So I'm really concerned that we don't get too far off our skis and that it's implementable, because right now this is great information and I enjoy the conversation, but how to implement is really scaring me and actually trying to deliver something by 1/1/23. Thanks for listening.
Thank you. And by the way, the delivery starts 1/1/2024. So you have an extra year in that. But thank you so much for sharing. Dawn.
Hi, my name's Dawn Felt. I'm the EMS and Education Training Representative. So I'm here kind of representing our EMS providers, EMTs, paramedics, first responders. The vast majority of our providers across the state of Washington, somewhere to 16 to 18,000, depending upon the day, are mostly volunteers. So the same thing that the previous speaker just mentioned is implementation, small unfunded mandate. So just want to make sure that we really do keep it as broad as in topics and just realistic to actual implementation, because the vast majority of our people are volunteers. So thank you.
Thank you for sharing. And I would say both Lori and Dawn, that's something else that we really do. And thank you for bringing that up. It's something that we do need to take into consideration. This bill also directs us to identify a free training program that is available for individuals that meet the requirements we write and roll. So it's also very important that we don't box ourselves in kind of this corner, which makes it really hard to identify free programs, or even for curriculum builders to maybe develop a program. And so we have to keep in mind this tension between, we want people to have this recognition and take action. We want professionals to actually use what they're learning, not just learn it and then, off to the side it goes, but actually integrate into its daily lives. But we also need a set of rules that not only are effective, but really in themselves, they're equitable too. And that's what I hear about is, I see traveling, 100 miles, and this is the same thing. And so I guess we need to keep that in mind. And so thank you so much for sharing about that. And I see Paula, and then we'll go to Christine.
Yeah, I wanted to address the issue of how the training is delivery and the traveling. So we have yet to do any of this in person. So we're doing all of this on Zoom. We've also been working with our instructional design teams to put together an online version using our learning management system. So we have already completed a 40-minute version that has all 5 of those content areas in it that we're using both at our, help me out, Lee, new employee orientation and as our annual refresher. So because there's 28,000 of us, right? So we know we're never going to get in front of 28,000 people in person. We also cover the WWAMI region, which is the 5-state region, Washington, Wyoming, Alaska, Montana, and Idaho. And we're putting together online versions. Those will be the 90-minute versions, but we've done really short versions. So this idea of traveling 100 miles, yeah, that's unrealistic. That's not going to happen. So there's nothing in this that I'm seeing that says this training has to be in person, right? So I think as we're building this, we should be thinking about how we're going to use technology. What really does the length of this need to be? So we've already begun to implement that. We know we won't have any new employee because that's what the other bill says. People have to come in. So we're making sure that they first get a taste with this 40-minute online version, and then as they are in their work, get situated into their workspace, then we get them registered and ready to do the 5 areas that are longer. So, but yeah, we've not done any training in person yet. So that eliminates the travel issue, at least.
Okay, thank you. Christine, you have the mic.
Thanks. I'm wondering for, like we've talked about the diversity of health professions, people having a desire for some flexibility, especially because there's such a difference between the different roles that are encompassed in this. I'm wondering if there's any discussion around or thoughts about having this initial training be kind of a platform, like we're talking about. A lot of this stuff is information that's relevant regardless of a person's healthcare specialty, but then beyond this kind of maybe initial series, for instance, if we were going with the UW model, these like 90-minute 5 modules, that those would be kind of an initial requirement by the department, but then beyond that, for these kind of 4-year intervals of requiring training, whether the department like doesn't necessarily develop anything else and just provide suggestions so that people can make sure that they're continuing to access trainings that are the most relevant for their particular specialties, or if they're already champions for this type of work, that are things that would be more advanced potentially, or like more kind of relevant for their current learning edge in terms of this material.
Thank you so much. I did notice the time. Let's take a 10-minute break, and then let's pick up on this topic again. And then I do want to bring up another question for you that a lot of people have been coming close to hitting. But so with that, let's do 10 minutes. I'll write in the chat again when to come back from the break. And that will be at 2:25 p.m. All right, everyone, welcome back. Hopefully you took care of your biological needs or stretched, whatever that looks like. So on this topic of what this training content looks like, it's important that we honor those who've shared their struggle with health inequities, that we create some sort of action, and that it's something that can apply to all professions. And of course, they can open up their rules if they're secretary of professions to further define that, or, you know, and of course, boards and commissions are their own rulemaking authority. So, and we need the equity of access to these trainings. Am I missing anything else that really needs to be taken into consideration when I further do some research and report back to you? And it should be trackable. Can you expand a little bit more on the trackable? You can use the chat if you want to. And Gail, your hand is up. You have the mic.
Yeah, thanks, Ashley. I just wanted to add one more thing, that there be flexibility. And that's consistent with the statute that says may include but not be limited to. So that's all. I just want to emphasize that again. Thanks.
Thank you so much. So that there's flexibility. So we'll add that in as well.
Yeah, hi, Ashley, this is Susan, and I was the one that wrote about the trackable for understanding what does and does not work.
Thank you.
Maybe we're not that far along yet, but I really do think that we need to have something to measure at the end of the day that says the efforts that we're putting into this right now can be monitored and tracked so that we know that we're on the right pathway towards achieving the objective of.
You're talking about quality assurance.
Yes, let's call it that. That's what it is.
Right. We want to make sure it's working and what we can change and.
Yeah.
Yeah.
Yeah, and there are ways of doing that, but I think it should be included in this. Thank you.
All right, thank you for sharing.
Mm-hmm.
And then I know that we're taking notes on that. And so you talked about quality assurance. I do have some questions for you in the training quality section. So Ross, when you're finished making your note, will you go to that section? In the meantime, what we'll do is we'll continue to work on this section. We'll listen back to the workshop, and we'll look at the comments and we'll respond, and we'll do some more research and provide you with facts and a list in the next workshop. All right. So this section right here, a lot of people have referenced it today. And I really, I guess, wanted to, well, first I'll provide you an overview of kind of what the bill does, because there seems to be some sort of maybe confusion or misunderstanding between what a secretary of profession is, what a board is, and what a commission. And this bill has a very wide net. Pretty much is saying if you're a healthcare professional under Title 18 and you have a continuing education requirement, this health equity is something that you need to have, this health equity continuing education. And so when we look at secretary professions, most of them will have advisory committees. And so what that means is they advise the Secretary of Health on maybe some things they say. That's taken into very heavy consideration, but ultimately the Secretary of Health has that authority for writing the rules. And so this what we're doing is we're developing that minimum standard. And with that minimum standard, not only are we talking about the quality of trainings or the topics of trainings, but we're also talking about what is that quality. And under the quality, it really goes to who can provide this training. So we had a bunch of ideas today, very, very good feedback. But now the question is, who can provide this? Now, boards and commissions, they're on their own rule making authority. And so they've been paying attention closely. All advisory committees, boards, and commissions really have had me go, and the few times I haven't been able to make it to that particular public meeting, their program managers have been really filling in those gaps. There's a few I haven't made it to yet, but they were also able to give some feedback. And also the rules are quite different. They say who can provide the education. And so I guess, so to clarify first, you know, there's 3 different types of professions: secretary professions, professions that have a board, and professions that have a commission. We're trying to keep everyone in a loop and engaged, but ultimately, when we're developing these, boards and commissions have this autonomy, right? They can do something different. So if secretary professions never define who can provide the training, we need to have something that's equitable, that shows, or there were some interesting things in the comment, right? Like one individual shared, hey, like sometimes we don't really talk about much, or someone will just log in for credit, but they'll be on the phone. And so how do we make sure that professionals are receiving that information and the guidance that goes along with that in a way that really makes a difference? And so we met a little bit with our health and equity and justice manager, health equity and justice manager, Omar, and he can't be here today. But we talked a little bit about what provides a barrier to receiving the training as well. And we listened to some of your comments that were put in last workshop. And it seems like having an active license to practice as a healthcare professional may be limiting, and the degree may be limiting. So I want to talk about this C or A that says at least blank years of experience delivering training in health equity. What suggestions do you have for changes? Do you think that should be a prerequisite? Will that impact the delivery of this training? And so I'm going to stop there. If you have any questions, I will qualify. I know I threw a bunch of information out there, but I really want to look at this section, this training quality, and really concentrate on, does it do what it's supposed to do? Is it equitable for our healthcare professionals? And also, is it equitable for the individuals providing the training as well? And so with that, I'll kind of stop. Paula.
So I can share with you, Lee shared that we have a peer trainer program that we have put together, and we asked ourselves some of these questions as well when we were putting together our training in terms of who should we be recruiting to be peer trainers. And we knew that it was going to be a barrier if we said that people had to have some years of experience or expertise in training for care equity, because we know there just aren't very many people. Like my office has the content area experts. There are some others out there, but they certainly aren't don't have the depth of knowledge. We just wanted to make sure that people had some baseline understanding of EDI principles and practices, and had some experience doing some sort of education and training. And then we were providing them the actual content expertise and even presentation skills. Lee's a master trainer on lots of different subjects, and he does a presentation skills. We brought in an outside organization to do how do you do conversations around equity, diversity, and inclusion. So I think it's going to be a barrier to put, you need X years of experience delivering training in health equity, because that's a narrow group of people.
Thank you for sharing. I really appreciate that. Jessie.
I really like number 3 about the data and that it needs to be referenced, recent, all of that stuff. But I do practical, like I think it's a really good parameter, but as someone going to the training, do I have the ability to suss out whether the training in fact meets those requirements? Or are we imagining a world where every trainer is saying like this meets the health equity requirement proposed by the DOH? Like I'm not sure that information will be available.
Thank you for that feedback. Dawn, will you share your?
Yeah, thank you. As far as developing the training, I think that having the training developed by people who are experienced in health equity training isn't a bad idea. I think that's probably a good choice. But when it comes to the people actually doing the training, for our rural areas throughout the state of Washington and our EMS services, so this is going to have to be implemented on a local ambulance by ambulance service basis. If we mandated in rule that the person delivering that a health equity training had to have so much experience, that would be a huge barrier for EMS.
Thank you for sharing. Gil.
Hi, thanks, Ashley. I really appreciate the comments of the previous speakers, and I agree with them. And I think, Ashley, is it okay if I also had a comment about sub 1 and sub 3, or do you want me to hold those?
No, you can go ahead and wrap it all into one.
Okay, thanks. I think one of the things to remember is there isn't going to be any entity to kind of review and approve and or monitor in terms of how continuing ed is normally done. So in subsection 1, where the language is completed evaluations will be returned to the trainer or publisher of the training, I don't think you need that language. And there's nobody who's really practically going to be able to double check that. And so I don't think you want something in rule that you essentially can't enforce. And then as I said, I agree with the comments about removing the years of experience. Sorry, I can't talk there. And in subsection 3, I would also remove the language about being current within 4 years. I know one of my colleagues with the Medical Association may speak to this, and they had an interesting suggestion that it be relevant to the course. I think you have to look at the practicality of this. And again, these classes aren't being set up to be approved. Who's going to check, double check? Are they current within 4 years? I think you're setting up a structure that, again, is just really not practical or enforceable. So thank you for letting me provide my thoughts.
Thank you for those thoughts. Christine and then Lori.
Hi, thank you. So I'm wondering, because I'm not that familiar with all the requirements for continued education, is this just an attestation that people have to make that they did complete this training?
Yes, that's a great question. So right now they would attest that they completed the training that meets the minimum standards written in rule.
Okay, so that goes to what she was speaking about previous.
Yeah,
All
and
right.
a professional could be audited based on
Right.
what is written in rule to make sure they completed that training.
And I imagine in the beginning, in particular, that auditing would be pretty intense. I would hope anyway, if you've got the bandwidth, right?
Good. Lori, your hand is up.
Yeah, Lori Grassi with the Washington State Chiropractic Association. With regard to your comment about tracking if somebody's actually on a Zoom call or not, or in the room or not, I mean, our continuing education standards in most of the professions are on the honor system anyway and audit based. So I would kind of challenge the comment about, I hope we would intensely audit this more than others. To me, an audit is an audit for whatever CE is required, and emphasis is done by each of the boards or commissions, and putting emphasis on one over another or a special set of requirements on one subject over another is not something that really has occurred, and not, at least not in most of the professions that I have worked with. So I just wanted to make that comment.
Thank you for your comment. I got another question around this based on what I hear. Is this section even needed, and can it be rolled into another section?
Yeah, I'm gonna jump in. I think we want to make sure that we have quality training. However, it was already stated, how are we going to monitor this? Who's holding anybody accountable to this? It seems like it's going to be agency by agency that would really be the ones that are going to be monitoring this and holding people accountable for it. So unless there is, one training that is going to be signed off on by some power that is, I don't know how you would actually be able to implement this part. So you don't want to put something down that you can't actually implement. That's my opinion.
Thank you for sharing. And I was on mute, so thank you for speaking up as well. Manjit.
Yeah, I just wanted to second that everything that has been put in chat, and thank you, Ross, for adding all of that in your notes in the document. I'm okay with this section completely going away or just being reworded instead of minimum standards for training delivery. If it was worded as, suggested guidelines or recommended standards, something that does sort of still speak to the need for keeping quality in mind when, sourcing content and for training our trainers, but then not making it so restrictive that then it starts to narrow our pool of resources that we can use, I think might be a way to address this too.
Thank you for that as well. And Jenny put in the chat, pretty much, will there be a list of approved trainings similar to the suicide trainings? And at this time, the professional would be able to find any type of training program that meets the minimum standards written in rule for this health equity continuing education. And they also need to abide by their profession's rule as well. So a lot of boards and commissions will define what this is. And so if we look at it from maybe even the secretary professions, right, which is a long list, the professional would be expected to read through this and make sure that whatever training they're taking meets that standard in place. And so this brings me to my last question of the night. We talked about the training quality, well, the training topics, a little bit about this training quality. But then we have this wild egg. And Ross, will you move to that section where it says the amount of hours? Boom, right there. And so we have different schools of thoughts on this, right? Some individuals are really for each profession opening up their rules and writing rules surrounding this and dictating how many hours of training need to be done. Or we can write this where it speaks to the professions that are secretary professions, and we can dictate that minimum hour of required education in this continuing education realm. And what if we go the second route, what is enough training? And so that's subjective, right? So any thoughts to this section anyone would like to share? Autumn.
Yes, hi. I'm just recalling how when we had to do HIV/AIDS training, that was a 7-hour requirement, and it seemed to pack in a lot of great information. And I just really like that whole structure, how they did that old the old way to do that.
Thank you for sharing. And I do want to add, this is every 4 years, this training, right? And it's really important to come from this from an equity standpoint as well. And so I'm going to be the devil's advocate here. I heard a lot of feedback from professionals. And the comment is this training, A, going to be on top of the training I'm already required to do? And B, for lack of better words, our time is not reimbursed for this course. Where are we going to find both the time to do this and the funds to do this, especially if this is unmandated? And so I would like to just throw that out there as well as some of the other school of thoughts. And I'm not sure if anyone else has anything else to say on that. Jessie?
Yeah, my reading was that it is within the hours that you're already required to take. Is that correct? So there shouldn't be, like, your time and your financial investment shouldn't be different. You'll just be allocating it towards a different topic potentially.
Yes, and so we did say that it was within that time that's already in there.
Thank you, that's super helpful.
Ross, would you be able to share maybe a little bit on the chart that you worked on, a little bit about CEs and the differences between professions?
Sure. Just after last week's discussion, I think we wanted to, as the departments, explore and make sure we knew when we were talking about secretary professions versus board and commission professions, what each profession's CE requirements were, both the number of hours and their reporting frequency, whether it be every year, 2 years, 3 years, when we were trying to think about if we specified a number of hours in health equity continuing education, how that would translate across, over 30 secretary professions, knowing that they all have varying reporting periods and number of CE hours. So ultimately, the information that we got is it is very variable, the number of hours between Secretary of Professions. Some require, as low as 8 or 10 hours that are due every year. Others have, upwards of 80 or 100 every 3 years. So it's really difficult to identify a specific number of hours that would fit well across professions. And kind of that's to Ashley's question, taking a step back, I think when we initially started this rulemaking, part of the thinking of including the Secretary of Professions in this first round of rulemaking, in addition to the minimum standards, was for efficiency, because there are so many professions under that, under the Secretary's authority, and how difficult that would be to do 30 some separate rulemakings to make sure that, each profession specify their own number of hours or incorporated the minimum standards in whatever additional rulemaking is necessary. And so that's kind of the underlying question that we're talking about here. I think when we're talking about the number of hours is, being efficient and trying to accommodate the Secretary of Professions, but also being mindful that within the scope of the Secretary of Professions, again, over 30 professions, that there are a wide variety of, hours that they need, as well as their reporting periods. So I'm not sure if that was helpful or not, but I'll give it back to you, Ashley.
Thank you, Ross. And we'll go ahead and call on Gail, and then Billy, and then Dawn.
Thanks, Ashley. 2 technical questions. I appreciated the comment that a previous speaker made, meaning are these health equity continuing education hours part of the existing hours and not in addition to? And your response was that they would be part of the existing CE hours, and I think that could use some clarification in here. And then finally, I think there should be clarification that the number of hours that are determined for the Secretary for Secretary Professions, but that the boards and commissions determine the number of hours for the non-secretary professions. And I think that needs to be specifically called out here.
Thank you for your comments on that, Gail. And that was a little bit of the conversation I had earlier today, is if we were to label the hours, how can we create language that says, Secretary of Professions, with the continuing education requirement that that don't choose to go above and beyond in their own rulemaking. So that gives me some things to ponder on. Billy?
Yeah, hi there again. This is Billy Dickinson with the Washington State Medical Association. Agree with Gail. We submitted some written comments to this point, but just really think it's important to emphasize adding language that clarifies that boards and commissions will have the discretion to set more tailored requirements based on each unique profession. I think the legislation recognizes that each profession has varying hourly CE requirements and licensure cycles. And I think adding some clarifying language here is really the most workable solution. Thanks.
Thank you for that feedback. Dawn?
So my question is there a requirement to list the minimum number of hours? And if not, could we do something and make it broad to say sufficient number of hours to meet the requirements listed in the, or the learning objectives in the above section? For some of our providers, they're required to do 15 years of education every 3 years because their initial course is 40 to 48 hours. So if we require every 4 years, they take an additional 8 hours, that would be really burdensome. And these are people in our rural areas that function the most.
Thank you for those comments. And that's something that needs to be taken in consideration, and I think has a lot to do with that research that Ross did, is how can you be equitable in prescribing some hours to meet that minimum requirement while not putting a burden on some of the professionals. Because there are professions, and correct me if I'm wrong, but it's 10 hours, I think, is one profession that has the least amount, maybe, Ross? And so without putting those hours down, we would then really rely on that profession itself to open up their rules. And so then you talk about, well, we have some deadlines, and is that feasible? And so just really remaining aware that A, people need the education, but B, we don't want to overburden professionals. Have topics that are considered important. What is going to be taken out of what has already been in So Betty, great question. And it goes to this, right? And it seems like I need to do some work on clarifying this language that, hey, you know, this isn't on top of other topics, but also there is this ability that if you do this training, it might also meet this training, and this training. Interprets the law. Second, the recommendation for 2 to 4 hours. We can send language after further review. All right. That's a great point. Please, you can also email your comments and anything else like that to the email address I'll put in the chat. Ross or Hope, I'm going to hand it to you for next steps. So I'll let you take it away.
Thanks, Ashley. And thank you to everyone for joining and providing the feedback. It's super helpful and we really appreciate it. Ashley kind of covered this a little bit, so I'll try to save some time. So we'll take the comments received from today's workshop, both those taken here and the ones that we do receive in our email, do our due diligence with the research and create a new draft of rules. That draft will be shared during the final workshop next or week after next. But it won't be the last opportunity to provide feedback. The next rules shop is going to be on Monday, April 4th at 1 p.m. A Gov delivery email with the updated draft and relevant information will be sent prior to the meeting. And then just further down the road, after the workshops, we'll speak with boards and commissions to get their feedback and make sure that we're all on the same page. And we hope to file our proposed rulemaking, which will include the proposed rule language in July. And then we'll have a public hearing, which will be ostensibly the final time that we'll have an opportunity to provide feedback, hopefully in September. And then after that, we'll go ahead and wrap up the rules process with the rulemaking order and finish the rules by the end of the year. And I think that's it. If I miss anything, please fill in, Ashley. Otherwise, I'll give it back to you.
That's great. To add, boards and commissions will be addressing this rule, and they have access to all the information that I have access to. So we won't leave them hanging. I'll be a resource to them. And then of course, we still need to identify our free training. So even though our rules will be wrapped up, we are not close to being done. We'll get to do this over again. So thank you so much for coming. Thank you for the conversation and all the comments. And please email if you have anything additional that comes up during the course of your day, or maybe you have some comments and whatnot. We will review those. So thank you all for attending and participating. I really appreciate everyone. Thank you.